Okay, welcome to our webinar. I'm Dr. David Krause, Chief Medical Officer of Genomind. For those of you who aren't familiar with us, we're a genetic testing company, a pharmacogenetic testing company located in King of Prussia, Pennsylvania. We were founded by a psychiatrist, Dr. Ronald Lourdes, about 10 years ago. And we have a pharmacogenetic test that's used by psychiatrists and other mental health practitioners to help select safe and appropriate pharmacotherapy. We've been used by more than 10,000 clinicians to help more than 260,000 patients in this country. And I want to mention at the start that in the midst of this COVID crisis, we've now pivoted to ship-to-patient assay kits. So it's not necessary that your patient be in front of you to obtain a buccal swab. We'll have more on that a little bit later. Well, our world has certainly turned upside down in the last few weeks, and we could not have imagined how this disease has changed our lives and those of our patients. It seems likely that COVID-19 and its consequences are going to severely and adversely impact the number of patients with mental illness in this country. We've heard predictions of increases in mental illness of 30 to 40%. There are already some hints that suicides may be on the uptick. And so it's going to be, we are facing a tremendous challenge. The challenge is also going to be the need for services. And we already have a shortage of health care providers, and in particular mental health care providers in this country. And one of the unanticipated consequences of the present events is that there's been a rapid shift to telehealth services, not just in psychiatry, but in all areas of medicine. And it seems likely that this shift will have some stickiness. Exactly how much we don't know. A lot of it is going to depend on the rules and regulations, many of which have received temporary waivers. We don't know which are going to sunset and which are going to stay in the long run. But the good news is that we're fortunate to live in an era when there are excellent technologies that are available to us, even in the most rural areas and even for individuals who are not technically capable. We know that the week of March 13th saw a 400% increase in the number of telehealth visits, and I'm sure that's increased since then. We know that there are many questions about telepsychiatry, including with respect to its effectiveness, particularly with the rules and regulations, the billing environment, and many of these are changing actually in a positive way in response to COVID-19. Next slide, please. We've assembled a first-class panel for today's roundtable discussion. I'd like to introduce them to you. Dr. Jay Fawver is Medical Director of Mind Body Wellness, which is a division of Parkview Health System in Fort Wayne, Indiana. Jay and his practice use a personalized algorithm for treatment approach, which includes pharmacogenetic testing in order to determine the ideal medication treatment. Dr. Fawver is a clinical professor of psychiatry at Indiana University. He's been named a Distinguished Fellow of the American Psychiatric Association. And interestingly, he's the host and producer of a PBS television show called Matters of the Mind with Jay Fawver, which is a 30-minute live call-in television show. Peter Yellowlees is a pioneer in telepsychiatry. He has more than 30 years experience in this arena. He's presently the Chief Wellness Officer of the University of California at Davis, where he holds the Alan Stoudemire and Dowd Chair in Psychiatry. He's past president of the American Telemedicine Association and co-author of Telepsychiatry and Health Technology. He's authored more than 250 academic papers. Jacob Harper is an attorney at Morgan Lewis Bacchius in Washington, D.C. He advises stakeholders across the across the healthcare industry, including hospitals, health systems, large physician groups, and companies like Genomind. And he has a particular interest and expertise in telehealth. And finally, Dr. Dowd is Vice President of Medical Affairs at Genomind. His duties include medical education, product development, pharmacogenomic clinical research, and Dan is an expert in pharmacogenomics, has published on its implementation in psychiatry, and he's been featured recently in the national media outlets, including Drug Topics, JAMA Medical News, and on the Dr. Oz show. Next slide, please. So what we want to accomplish today is to provide some insight into the advantages and efficacy and limitations of telepsychiatry. And we hope to gain some insight into the practical usage of it and how one might switch in a modern psychiatry practice to telehealth. We want to discuss the evolving regulatory situation in light of COVID-19. And at the end, I'll talk a little bit about Genomind's express ship-to-patient feature for pharmacogenetics, and also mention a couple of companies that we have partnered with. Next slide. Disclosures and conflicts of interest are up on the board. Really, there are very few. And Dr. Dowd and myself are employees of Genomind, and Mr. Harper is an employee of Morgan Lewis, and Morgan Lewis is a contractor to Genomind. And I want to let you know this event is being recorded. Obviously, you're seeing it in a recording. Next slide. Okay, so I envision this as being kind of a roundtable discussion. And let me start off with Dr. Peter Yellowlees. Dr. Yellowlees, you've been utilizing telepsychiatry for decades. So if you would give us a brief overview of your journey, what prompted your initial interest, talk about the timeline of the uptake of telepsychiatry, and also a little bit about the efficacy of telepsychiatry compared to traditional psychiatry.
Sure, of course, David, and it's very nice to be here. Thank you for inviting me to take part in this, and I do hope that this is helpful for anyone who's watching who might wish to, continue the switch to telepsychiatry. So I saw my first patient on video back in 1991 in Australia, where I was living at the time, and I really got involved in this because I was the only psychiatrist living in Central Australia, looking after a population of about 30,000 people, covering a landmass the same size as California. So I literally used to fly 300 miles each way to do clinics. And so I got involved in using technology to see patients. At that stage, email was just coming in, obviously phones. And then I started a trial using video conferencing. Very different in those days from now. I literally had to get a $500,000 grant to be able to afford to buy 2 video conferencing boxes to set up in 2 positions. And essentially since then I've been interested in the whole issue of how do you improve access to care for patients, and I've worked on that really ever since. But I come at this primarily as a clinician trying to solve a problem. I think that's really why we're all here today, because obviously the most recent problem has been that everybody's been told to go home, and so they can't attend clinics, and we've had to deliver our psychiatric services as well as many other medical services in a very different way. So briefly, I guess about telepsychiatry in particular, there's been a lot of research over the years in this area. It's been shown that essentially there are no exclusions for any particular group of patients. The only real exclusions are if patients literally refuse to see you on video, or if they are actively homicidal or suicidal and doing something damaging or self-harming at the time. But apart from that, all types of patients have been seen and treated. We know that patients are really satisfied by getting this approach to care. There's been multiple studies looking at patient satisfaction, and it's actually often higher for patients receiving care by video than it is for in-person treatment. That's not surprising because it's generally so much more convenient for patients and giving them much better access to a specialist, and also seeing a specialist in a less threatening environment, typically in their own clinics or in their own homes. So the third thing that has been found is that there are 2 major sets of barriers to implementing telemedicine. The first is the attitude of clinicians. Unfortunately, many physicians and other mental health professionals still do see telemedicine as being not as good as in-person care, whereas in fact, there is actually quite a lot of evidence that with certain groups of patients, it's actually better than in-person care. So patients who are phobic, who are anxious, who have very stigmatized problems, often actually prefer being seen on video, as do children. So the second set of barriers, up until about 2010, were technology related, but really since then, there hasn't been a major technology problem, and most people now can use very simple devices. I actually frequently just use phones or laptops, you know, physicians and patients are all fairly mobile people, and I think the beauty of seeing people on video is that you can actually work in a mobile environment. So I actually encourage, for instance, many of my patients that I'm seeing at home to actually see me in their cars if they're working, because the car is actually the most easily available, completely private area for someone to have their consultation in. Now, so the other barriers that are still, or have been until recently a problem, are regulatory and administrative. And there's been huge barriers in this country in terms of licensing, reimbursement, and the administrative processes involved in both you know, doing and getting paid for these services. And I'm sure we'll be talking about how that's changed in the setting of this crisis shortly and during this, this whole session.
You preempted one of my questions, Peter, and that had to do with children and adolescents. So a large fraction of our customer base is are teenagers. In fact, if you look at the modal distribution of patients who get tested with our pharmacogenetic assay, the mode is about 18 years of age. So of course, a lot of these young people are digital natives, but what about children and older children?
So I mean, children, you know, as you well know, tend to be, you know, more self-focused. They see the world through their own eyes, not so much through other people's eyes. They can't understand why we don't do this all the time and why have we been so worried about seeing people on video. I've been seeing children literally for, you know, almost 30 years now on video. They, you know, generally have absolutely no problems with it, are, you know, accept the whole process very easily. It's just straightforward. They just simply look at us as being rather out of touch adults for not being more interested in doing this.
Right. Dr. Fawver, you run a very large psychiatry practice in Fort Wayne, and you are a new adopter of telepsychiatry, and I guess that your hand was forced by the present crisis. Tell us about how you went about moving your large practice to telepsychiatry almost overnight, and what were the lessons you learned, and what technology do you use, and so forth?
David, in Fort Wayne, myself and 10 nurse practitioners, we take care of 8,000 patients from a psychopharmacological standpoint. And we've done 100% in-office visits for several years. I remember, like with Dr. Yellowlees, my goodness, 1998, I remember seeing telemedicine used for the first time ever, and I thought, how could I ever do this? And as time has gone on, there are so many regulatory restrictions in the state of Indiana for us to be able to do it that we just couldn't do it. The originating site had to be in a physician's office, which kind of takes away from many of the benefits of doing telemedicine. So on March 23rd, we were informed that our governor was going to have a shelter-in-place order invoked in 2 days. So on March 25th, we went from 100% in-office visits to 100% telemedicine. Now, we're fortunate enough to be on a electronic medical record called Epic, and many people are on Epic. We use the platform of MyChart. Our patients will log into MyChart. Through there, they will update their past medical history. They provide their outcome metric questionnaires that we typically use, such as a PHQ-9, GAD-7. So we have that all preloaded through the portal before we even see the patient. And as of March 25th, we've seen about 800 patients over the course of the past 2.5 weeks with telemedicine visits. Our providers 100% are on board with it. Our patients have been very enthusiastic about it, and they want to see us continue to do it indefinitely at this point.
So the patients You send the GAD-7 or PHQ-9 to the patient ahead of time on your portal?
The outcome metrics questionnaires are already preloaded on MyChart. So specifically, we use the GAD-7, the PHQ-9. We use a perceived deficit questionnaire, 20 questions on that. We use the patient-rated inventory of side effects, the PRIZE, which was used in the STAR-D trials. And we also use various other screening scales based on the patient's needs. So those are already preloaded in MyChart. We give the patient a couple days notice, remind them within a couple days of their appointment to start filling out these questionnaires. And as I mentioned, very importantly, we have them update their medications, their past medical history, their family history. And we have that as soon as we open up the video chat visits at the time of the appointment.
So what do you do? Are the visits typically recorded, or do you then write notes after the visit? How do you document and codify the visit?
One of the disclaimers we have the patient agree to will be not only that we can do a video visit, that we specifically say they are not being recorded, and we're doing so on a secure line. So with that being said, the patient is in our practice on an iPad, so we can see the patient on the iPad. We have the video visit there. We're typing on our PC or laptop during the visit itself. We send out the orders to the patient. The patient has the after visit summary available to them on MyChart on the portal, so they can see that. And the prescriptions go straight to the pharmacy.
Okay. Jake, I'd like to turn to you for a second. There is a perception that telehealth has been slow in arriving, in part because of the barriers, including not the technical barriers necessarily, they've been solved for a long time, but the morass of federal and state rules and regulations and legal issues. Recently, in the face of the COVID crisis, the CMS, HHS, and the FDA have all relaxed some of their regulations, at least temporarily. So could you briefly discuss some of these changes? Which rules do you see sunsetting? Which do you see becoming permanent? And if you could just discuss the interim final rule that came from CMS.
Absolutely. And thanks again for having me. A pleasure to be here. I just want to reiterate, I think Dr. Yellowlees hit the nail on the head on sort of the two main issues, absent the technological barriers that providers are having to face right now. Licensure is certainly a big one of them. And the other that I think is really impactful for everyone is reimbursement. I think when I talk to healthcare providers, across the spectrum who are interested in telehealth services, the number one, probably number two, and number three answers they give for why there's an issue here is reimbursement, right? Is the concern that they're investing a lot of money in technology, a lot of time in trying to switch to these kinds of services, and they're worried that they're not going to get paid for it, and that's a very legitimate concern. Over the past month, there have been just an enormous amount of changes, and in my role as an attorney who's typically defending healthcare providers, I'm often critical of the federal government and CMS and HHS, and certainly sometimes state authorities as well. But here I have to say that they've done a really incredible job in the past month of trying to help the healthcare community pivot, as Dr. Fawver was saying, basically overnight from, 100% or 90% in-person services to, the opposite, 90 to 100% telehealth services. So, the main issue, at least in the Medicare program, which is sort of where we look at for reimbursement, and some states follow this, although not in the same way. But the main issue that we often focus on is the originating site requirement and the geographic requirement, where you'd have to have a patient who is in a rural area and at a originating site, which is typically either a physician's office, a hospital, a skilled nursing facility, something like that. So it basically entirely defeats the purpose of sort of what we think of as telehealth right now, as a person who's in their car or in their home, or if they can do it at work, receiving services via their phone or via their computer. It really defeats that entire purpose. So those requirements on March 6th through the first coronavirus bill were waived for Medicare patients. Some Medicaid programs have already eliminated those restrictions, and commercial programs are, kind of all over the board with respect to how they approach telemedicine coverage generally, and certainly telepsychiatry. There was also the CARES Act, which came out, and this was sort of the stimulus bill that everyone's thinking about. It came out a few weeks ago. That had a number of additional provisions related to telemedicine services generally, and basically stood for the proposition that people need to be receiving services in their homes, in accordance with social distancing rules and the quarantine. They need to be receiving services in their homes across the gamut of the healthcare spectrum. That led to the interim final rule that CMS issued on March 30th. So we've had that for about a week and a half now. And this was, again, a triumph, I'd say, of the regulatory process. They effectively relaxed the rules related to Medicare coverage for telemedicine, which includes telepsychiatry, across the board. And so from restrictions related to new or established patients, they said it can be anyone here. They expanded the modalities to allow not only for live audio video communications, but even in certain situations, telephone visits, right, which historically they have not wanted to cover. And so they've really done a tremendous job of opening this up. I know, I think we're thinking right now about live audio video, but certainly Medicare and even some Medicaid programs. I know Texas, for instance, is one of them. They've allowed telephone audio only visits to be covered, not just provided, but also covered. So it's been a really remarkable change over the past about month or so.
Well, what about for the commercially insured patients? Because the interim final rule only applies to Medicare and Medicaid, is that right?
That's correct. Yeah, and really the interim final rule is very much Medicare focused, not even Medicaid so much. Commercial payers, as I said, have been across the board historically for the last 10 years or so, when the telehealth dialogue sort of started to come into play in a real way. Some have embraced it. Some have said we're not going to cover these services. Some have created sort of limited offerings where they might have a very narrow network of providers that they work with on the telehealth side. And so you've seen a huge diversion in terms of how commercial plans approach these things. Over the past month, either because the plans themselves have decided that this is the appropriate way to handle this, or because they've been ordered to by a state insurance commission, they've taken a number of affirmative steps, including waiving copays for these services, enhancing their enrollment processes, and providing additional coverage via telehealth more broadly. So again, those policies are ones that tend to be provider specific because they're contractual in nature, right? They have a policy manual that sort of they can adjust, but those have been a pretty significant change as well.
Where do our customers go, our providers go to find out all the various CPT codes? Because it seems like there's quite a few of them, depending on where you are, how long your session is, and so forth.
Yeah, I mean, there are certainly a number of CPT codes, but so the CPT is something that's developed by the American Medical Association, and they have a particular committee that's in charge of that. So you could certainly go to the AMA's website, as well as the Medicare program. CMS has its own what they call the physician fee schedule lookup. And it allows you to evaluate, what particular codes there are. And so, for For psychiatry in particular, there's a set of codes that can be provided. There are, in the interim final rule, telephone-specific codes that you need to evaluate. So those would be available. You'd have to sort of dig through the interim final rule to dig those out, but the AMA and CMS websites are very good resources for that.
So now the requirement that the provider be licensed in the state where the patient is receiving care is temporarily waived, at least by CMS. Is that correct?
Yeah, so that's a very complex legal issue. So licenses are not federal in nature, right? They're based on each state. So Dr. Yellowlees being in California, he has a particular license in that state. Dr. Fawver in Indiana has a different license specific for that state. What CMS and really the federal government generally did on March 15, which was retroactive to March 1st, was they said, for purposes of the Medicare and Medicaid programs, there's typically a limitation that if you aren't licensed to provide a service, we're not going to pay you for it. And what they said is, we're going to waive that requirement during the crisis. And so even if you are not technically licensed to provide a service, we'll still pay for it. That's really only one half of the equation, though, because physicians and other healthcare practitioners need to nevertheless have the authorization to avoid instances of malpractice, allegations of practicing medicine or psychiatry without a license, et cetera. And so you need to have the states also be on board with that process. There's really three ways that states have approached licensing in this temporary period, and a fourth issue that I'll talk about. A number of states have kind of gone along with the same federal government approach and said, we're also waiving our requirement that you be licensed in our particular state, so long as you're licensed in one of the other 50 states in the country, in DC, right? So, New York, for instance, given the crisis that they're acutely facing right now, they've said, if you're licensed in another state right now, you can provide services here. Other states have taken a, not as dramatic an approach, but they've said, we're setting up a very quick temporary licensure, expedited emergency license process. So Texas, for instance, you can get a license in Texas in sort of a 24, 48-hour time frame. North Carolina, for instance, similar, where you aren't automatically licensed to practice there, but if you want to practice there, you can with little effort get that going. Some states at this point in time have not taken any additional action. I know, this was a few days ago, but Ohio, for instance, hadn't created a special registration process or licensure exemption process at this point. But again, that could change as the virus changes where it's affecting the population. And the last thing to think about in the licensure aspect is what's called the Interstate Medical Licensure Compact. And this is an agreement of currently about 28 states. There's more that have pending legislation, but I don't think that they've been passed yet. But the IMLC is what we call it. And that allows you to, if you're licensed in one of sort of the host states, and one of the member states, you can then immediately apply for licensure in all the other states. Again, it's not an automatic grant of a license, but it makes that process very smooth, and you can apply to all of the other 27 member states with the click of a few buttons and paying a lot of money in the process. But so you do need to still maintain licensure unless the state has specifically waived it.
Well, it's like the waters are going to be choppy for a while.
Yeah.
I mean, with 50 states and the federal government involved, and everybody's got an interest.
Their own way of, their own way of doing things.
It's hard to know how things will fall out, but it does. I mean, I do get the feeling that in the long run, the axis will tilt more towards telehealth than it has been.
Yeah, that's absolutely true. And I mean, I think, Dr. Yellowlees, as you know, psychiatry in particular, just because of the nature of the service, has long really been something that I think has made sense in sort of providing services virtually through interactive communication technologies. And so I view this as sort of a dress rehearsal for the wider adoption of telemedicine and telehealth generally, right? I mean, it's not something where it's been so on the sidelines that no one's ever thought to use it, but it has been something that has again been reimbursed at either insufficient rates or not reimbursed at all due to statutory and regulatory restrictions on it. I think there have been some efforts, both federally and in a lot of states over the past 4, 5, 6 years to liberalize our sort of telehealth policies. And the potential for that, I think, is only growing to grow so long as this, achieves the aims that we're trying to achieve here. So, obviously increased access, maintaining similar types of costs, and maintaining quality care, right? I mean, I think that's one of the things that I can't sit here and address, but I'm sure that the doctors here can of saying we need to continue to provide the same quality, and if we can keep it the same or raise it and avoid instances of widespread malpractice, that's going to be something where it's going to be really really good for the healthcare community to show that this is an effective mechanism to provide services to patients who are in need.
So Peter, you've done some research on the effectiveness and on quality of care from telepsychiatry. Can you comment on that?
Sure. Well, I mean, we know that the quality of care is similar in using telepsychiatry to in-person. There's been multiple studies showing that, and that in some instances it actually may be better. For instance, with children and with patients with PTSD and with severe avoidant disorders. My view is that there's really no reason for people to try and use that excuse to not do telepsychiatry. I'd like to also just comment on some of the recent regulatory changes, because Jake covered the two major areas really, really well. The issues of the licensing and the reimbursement and insurance. But there's two other areas that are very important for clinicians as well that were changed. The first one was about prescribing and prescribing of scheduled drugs. That for many long, complicated historical reasons, it's not been previously legal to prescribe any scheduled drugs. I have been fighting with the DEA for 10 years on this issue. And they've been intransigent. And overnight, we've suddenly been allowed to prescribe scheduled drugs. Now that's really important in terms of being able to prescribe stimulants, benzodiazepines, and potentially buprenorphine and drugs for addictions. So we can now do that in this crisis. And I really hope that like the licensing and the reimbursement changes, I hope that the prescribing changes actually persist after this crisis is over. And I think one of our next jobs, and one of the jobs of everybody listening to this call, is to speak to your congressman to actually keep these changes in place, so that in the new normal world that we come to within, I hope, the next few months, we can actually keep a lot of these changes and continue to give patients much more choice and better access to care. Now, the other change that has occurred that I don't want to continue is that we're allowed currently to use non-HIPAA compliant systems to do our consultations. So you can charge if you want to use FaceTime or Google Hangout or anything like that that is non-HIPAA compliant to see your patient. I think in the long run, that clearly should be reversed, and we should be using HIPAA compliant systems. And I'm guessing that that's what's going to happen. And so I'd suggest that anybody who's moving into this area for the first time and who's watching this broadcast, still try and use HIPAA compliant systems. You may want to practice with a few patients using FaceTime, but try and move to a HIPAA compliant system pretty quickly, because I think you'll need to do that in the future.
Yeah, and that's I think those are both fantastic points, Dr. Yellowlees. So if I could just respond to both of those, first with respect to to the issues you raised with the DEA, completely agree. One of the things that we did see in law was that, as you mentioned, what you're talking about is really what's called the Ryan Haidt Act, that basically prevents the sort of what we understand to be the typical telehealth visit from being something that you can prescribe a controlled substance for. The DEA has long had the authority to create what's called a special registration to allow those telehealth providers who've, and they haven't ever issued sort of the guidance on this, but allow those telehealth providers who kind of prove out or get accreditation or some certification that say, I'm a legitimate provider, I'm using this for a legitimate purpose, to actually provide the services through that special registration. They've never issued that. And in the Support Act, which was passed in the end of 2018, the DEA was given a deadline of October 24th, 2019 to actually implement the special registration. So they've been sat on it for 10 years. And then, Congress said, a very bipartisan group of Congress said, you need to implement this special registration process, and we're going to give you 1 year to do it. Well, October 2019 came and went without anything. I think as the psychiatrist on this conference can attest, that was a problem for a lot of telehealth providers, because that was intended to be a really important game changer. So now we have this situation here, which I agree. I think if you contact your congressman and certainly can provide evidence that these services are not being abused, and providing controlled substances is an effective means to treat patients, that's something that the DEA is going to really have to react to at this point. The second point to address on the HIPAA side is also very, very important, particularly, and this is one of the main areas where I think telepsychiatry varies from sort of the general telehealth practice. The OCR, which is the federal agency responsible for overseeing HIPAA, did indicate that they were waiving their enforcement discretion if a practitioner was to use a non-HIPAA compliant platform for providing services. So whether it's FaceTime or Skype, if they were to use those types of services in good faith to provide services on a one-to-one basis with a patient, that would have been okay, and they wouldn't enforce that. They did specifically say that you couldn't use things like TikTok or other public-facing apps. I think there's a Facebook Hangout or something like that, or a Google Hangout that might involve a bunch of different parties, and that those would not be protected from HIPAA enforcement. OCR also specifically said that HIPAA is not waived during this crisis. And so, one of the things with telepsychiatry from a HIPAA standpoint is there are really heightened rules related to this because of the sensitive nature of psychiatric practice, whether you're talking about, mental issues, even substance abuse type issues. All of those things are protected under what we call Part 2. And so those are special heightened rules for HIPAA, for patient privacy and security that psychiatry practices often need to comply with, just given the nature of their services. In addition, there are state laws in basically all 50 states that apply to protect patient privacy that are separate and apart from HIPAA. And so you do have to contend with those state laws, which to my knowledge have not been waived in any capacity at this point. So Dr. Yellowlees is absolutely correct that should not treat the OCR waiver as something that is a free-for-all, and providing services through a HIPAA compliant platform is going to be important now and in the future.
Thank you, Jay. Jay, I just want to turn the last few minutes to how you work with people who might be older people who might be technologically challenged. Do you ever use any ancillary devices that might be more in the primary care arena, like blood pressure or pulse oximetry in the current environment?
David, I know in our case, we have some older people who aren't very technologically savvy, but you'd be surprised how many of them are. But in that case, they will recruit the efforts of their family members. Many times these people come in with daughters, sons, and those daughters and sons are helping them with the devices. And we're able to watch them in that manner. Many people do have access to blood pressure monitors at their homes, and we will have them check their blood pressure at home. We'll have them just get a weight for us to get us an idea. But over the course of time, we expect that we'll be using these ancillary devices more and more. We have a lot of people who have biometrics. Cardiology has been doing this for years, where people have at-home biometrics where they're able to check electrocardiograms and transmit it over the phone. I think we'll have the same thing in psychiatry in terms of being able to assess people for their vital signs, but that has not been an obstacle for us one way or another right now.
So do you have family members sit in on the sessions by telehealth?
We've actually encouraged family members to sit in if the patient wishes to do so. The family members might be in the next room. I'll ask somebody, for instance, how does your husband feel like you're doing? And the woman will walk right on the corner and talk to her husband. Another interesting aspect is sometimes I'll ask people about their other medications. If they're in my office, they might not be sure. These people are literally walking to their medicine cabinets and showing me the other medications they're taking. And that's been a huge benefit for a lot of my patients.
Yeah, I hadn't thought about that. That's an actual advantage of telehealth. We've got about 10 minutes left, and I wanted just to turn the page, talk about a couple of collaborations that Genomind has with a few partners. And then finally, we'll ask Dr. Dowd to talk about ship to patient for pharmacogenetics. Next slide, please. So Genomind has partnered with a company called NeuroFlow. NeuroFlow is a company that's local to us in Philadelphia. It was founded by a combat veteran Army officer who had some issues with his staff and some mental health issues with his troops in Afghanistan, and he started a company, and the company is called NeuroFlow. And the role of NeuroFlow is to connect providers and patients electronically, but this is a little bit different than telehealth because this is essentially asynchronous. So the patient will download the NeuroFlow app on which he can collect data. The provider and the patient are connected, and the provider can send various instruments to the patient and keep track of the patient. So it's kind of quantitative tracking of patient validated instruments, and there are various incentives and so forth for the patient to complete the tasks assigned. Next page, next slide, please. So you can see that the provider can select the appropriate validated instruments that are specifically tailored for the patient. And I believe that NeuroFlow would even work with the provider to, if there were validated instruments that were not seen here, I think the NeuroFlow could help you utilize the validated instrument loaded in. And then next slide, please. The provider can then actually track the patient over time. So here you see an example of a patient with depression, and you can follow serially the PHQ-9 scores. And at some point, the provider sees these scores deteriorating, he or she may intervene. So that's NeuroFlow. This also is something that's maybe reimbursable to the provider depending upon the patient's commercial insurance. Next slide. I also want to mention that we partnered with a company called ShareCare. ShareCare is a large digital health company, probably the largest digital health company in the world. They have a variety of platforms. They provide services to patients, payers, governments, and so forth. And in the face of the COVID-19 crisis, they've launched their own secure video chat program called ShareCare Telehealth Solutions. I'm not going to go through all the bullet points. I'll tell you that I've had the opportunity to test it out. It doesn't require any software downloads with respect to the technologically challenged. It's incredibly easy to use. The provider can keep notes in the sidebar while interviewing the patient. The provider can take screenshots to view later. The provider can send a summary of the encounter to the patient. So this is what we talked about. It's HIPAA compliant, and it can also be used for the previous appropriate instruments that we mentioned. It seems quite intuitive and easy to use. Next slide. Just to let you know that that ShareCare telehealth solution platform is going to be free until September 1st, 2020. Thereafter, the price will be, there will be a monthly fee. If you're interested in that, you can register at the link that I show here, and we will provide to all of the registrants on this call after the meeting. Yeah. Okay, so finally, next slide, please. One of the things about telehealth is that the patient is not sitting in front of you, and if you're interested in obtaining a buccal swab to do a pharmacogenetic assay, that's not going to work by telehealth. So Genomind has trying to keep lockstep with our patients and with our customers, our provider customers. We've recently launched Genomind Express ship to patient kit. So if you want to get pharmacogenetic testing for your patient, you will go to the provider portal that Genomind provides, just like you always have, to requisition an assay. However, in this instance, we will ship the kit to directly to the patient's house. We'll ship it over to FedEx. We'll eat the cost in both directions. Patient does the buccal swab, sends it back to us. So Dan, tell us, just tell us briefly how that's going to work.
Yeah, thanks, David. So if you haven't done genetic testing before, it's extremely easy to do. It's a cheek swab. It's simple, it's non-invasive, and patients can easily do this on their own. So next slide, we'll walk through the process that we tried to make this as user-friendly as possible. If you have used our clinician portal before, then it's a simple login as usual. You just click on clinician portal login. If you have not used Genomind for genetic testing, then you click the Contact Us button and you can fill out a form, and we'll get you set up, get you set up in portal pretty quickly and easily. So once you're in the clinician portal, next slide, please. You'll notice on your left-hand side, there's a requisition option. Now, this is the same way you would do a traditional requisition, a traditional in-office requisition, but it's also the way you would do this, this ship-to-patient requisition kit. So you click on that, that brings you, next slide, please, that brings you to our Create New Requisition section, and newly added is this Ship Kit to Patient functionality. So if you want to send a kit directly to the patient's house, you would click this button. That changes some of the fields that are available to you. And really all you need to worry about after clicking Ship Kit to Patient is identifying the test that you want to ship to that patient. In this case, it would be Genomind Professional PGX. And then also identify the collection state. That's the state that the patient is in when they do the cheek swab. So identify the test, Genomind Professional PGX, and the state that the patient is in. From there, it'll prompt you to add the patient demographics, name, birthday, and probably most importantly, the address, so we can get the kit to the patient's address. Okay, next slide, please. At that point, you send, once you acknowledge that, we will ship overnight, ship a kit to the patient. And then as a provider, you can track the progress of that kit. You can determine whether the patient received it, whether they've swabbed, whether they've sent it back. And then once we get the results, we can usually, once we get the sample, we can usually have the results back to you in 3 days or less. So we've tried to make this as user-friendly as possible, and this is available to all clinicians at this point. David, back to you.
Dan, you just want to you might just want to mention our consultation services.
Yeah, so if you used Genomind before, you know that we offer consultations for every report that comes through the door. We're very proud of our consultations. We have a team of pharmacists and PhDs that are available to help you with a new report, or if you have a particularly complicated patient, we're happy to walk you through that report. We offer an on-demand clinical consult service now, where if you have a quick question, you can have immediate access to one of our consultants. So again, that is live, and everyone who orders a test has access to that in real time.
Okay, thank you, Dan. There's 2 minutes left, and I wonder if any of our speakers have any last words of wisdom. Peter, what do you think the world's going to be like in a year with respect to telehealth?
So I think the really big change that we're going to see is something that Jay hinted at in his last talk, which is that we're going to have the return of the home visit. I mean, when I see patients at home, I actually ask them if they could, for preference, use their phones or iPads at their end, because what I like doing is getting them to pick up their phones and their iPads and show me around their house, take me out in the garden, show me where they live, give me much more of an idea of what their normal living environment is and what they do, what their interests are, what their passions are. I like to meet their family, I like to meet their pets. I actually get a lot more information out of doing home visits on video than I typically do through seeing people in my office. So I think we need to think of the virtual home visit now and start seeing more and more patients in their homes. And that will actually make a huge difference to the practice of psychiatry. I can remember as a young psychiatrist doing a lot of home visits, but that's really not happened in the last 10 or 15 years. And I think we can now do that. And so we can actually go back to a better way of practicing using video.
This might be a little bit out of left field, but what about, is there a role for virtual reality?
You know, I think there's going to be a whole series of other technologies. If you look at artificial intelligence, for instance, I mean, with consent, you know, we could record people, we could develop sort of screening tests for depression, for instance, by looking at voice and language and facial expression, testing and using a number of AI type techniques. So I think we've got the potential to develop a whole series of screening tests. I think we're going to be doing a lot more asynchronous work. I mean, at UC Davis, we've been using asynchronous telepsychiatry now for about 7 or 8 years, where we actually record patients that are interviewed by a trained interviewer, and we then send those recordings for an opinion to a psychiatrist somewhere else. And that, again, is a very simple, straightforward process that provides patients and their primary care physicians access to opinions from psychiatrists, just as if they were getting an opinion from a radiologist on a chest X-ray.
That's interesting. Could that be useful for a second opinion also?
Very much so. I mean, we've been doing this now in primary care and in nursing homes. So, for instance, we have a trial, an NIH-funded trial going at the moment, looking at nursing homes, where we're comparing the effectiveness of synchronous consultations versus asynchronous consultations to actually treat people over a period of 6 months at a time in a nursing home, which is a place very few psychiatrists actually ever get to, where there is a huge need. So I think these asynchronous consultations for opinions and for monitoring people over time are potentially very powerful.
And that's absolutely right. So most states, over the past 3, 4, 5 years have liberalized their policies to not only include live audio video, but also include asynchronous communication, sometimes referred to as store and forward. One important caveat on all this, the lawyer here. So, one thing that you do have to recognize, whether you're providing services in person, real time, async, most state boards specifically say that the standard of care does not change depending on the modality you use. So, you need to approach every type of encounter with a patient, even if it's asynchronously, with the same degree of professionalism and and seriousness, because all of these visits are looked at from the purposes of sort of the standard of care under the same microscope.
Thank you, Jake. I want to thank all of our speakers today. We've come to the end of our hour. Could we have the next slide, please? Because this event is being recorded, if you're viewing this, here are a number of resources that you can use. And you can always call Genomind customer service for further information. I've given you the email addresses for Mr. Harper, myself, Dr. Dowd, not for the other physicians, but if you want, it may be possible for me to connect you with them. Also, there's a plug here for Dr. Yellowlees' book, which is a seminal book called Telepsychiatry and Health Technologies. I want to thank everybody who participated today, John Levine, our IT person behind the scenes, and hope everybody stays safe and we come out the other end of this tunnel very soon. Thank you.
Thank you.
Thank you.